I'm Michael Betel, president and founder of the Fatty Liver Alliance, and I'm here today with three very special guests for an encore fireside chat. Dr. Mark Swain, hepatologist from Calgary, Alberta, Dr. Naim Alkhouri from Arizona Liver Health, and Dr. Tracey Simon, assistant professor of medicine from Boston, Massachusetts. Today, we're going to discuss Dr. Simon's very recently published paper, Mortality in Pediatric and Young Adult Non-Alcoholic Fatty Liver Disease, results from a nationwide histology cohort. So Dr. Simon, welcome. And could you please tell us about this important paper and why it's so significant now?
Thank you so much, Mike. I am thrilled to be here with all of you. We wanted to do this study because we know that there is a growing global epidemic of obesity among children and young adults. We know that non-alcoholic fatty liver disease is a growing problem among children and young adults, both in the US and Canada and elsewhere. But there's not a lot of longitudinal data from large populations to quantify what the prognosis is and what the long-term outcomes are for those children and young adults who are affected by Nafld. And so we use the Swedish nationwide registers to try and get some better estimates to better understand the complications of Nafld and the risks of overall mortality in children and young adults who are affected by this disease. I'm sharing right here our figure. So just to back up, what we did was we used the Swedish registers and we identified 718 children across Sweden between 1966 and 2017 who had a diagnosis of biopsy-confirmed Nafld. We matched them to general population controls by age, sex, county of residence within Sweden, and calendar year of diagnosis. And then we followed them longitudinally for overall and cause-specific mortality. So what's shown here is the cumulative incidence of overall mortality in these pediatric and young adult patients who are yet less than 25 years of age at the time of diagnosis, and then their matched population comparators who are shown in red on this figure. And as you can see, the rates of overall mortality were significantly higher in children and young adults with biopsy-confirmed Nafld compared to the matched population controls. To give some specific estimates, we found that after 20 years, the absolute risk of mortality was 7.7% among the Nafld population compared to just 1.1% among the population controls. And after adjusting for comorbidities, this corresponded to an adjusted hazard ratio of 5.8 with a 95% confidence interval of 3.7 to 9.2. So this was very striking to us. And we also were very interested in looking at whether simple steatosis or NASH corresponded to different rates of overall and cause-specific mortality. And so when we specifically evaluated simple steatosis and NASH, we found that the highest risk of overall mortality was among those children and young adults who had biopsy-confirmed NASH. And their risk of overall mortality was 11.7-fold higher than that of matched controls. And so, you know, what that shows is something that many of us have long suspected, which is that Nafld is not a benign disease. It is being diagnosed earlier and earlier in younger populations, and it is a condition for which we really need more aggressive early interventions and preventive interventions at the population level to try and keep our children and young adults safe.
Okay. So maybe I'll just start off, Tracey. I mean, first of all, you know, again, congratulations. Just like in the last, these encore things are actually quite fun because it's like a continuation, right? Never-ending story. But you know, it's you know, obviously this is an area that is really underrepresented, and I think you know, you point out so nicely in your paper that a lot of the studies we look at have very, very small numbers of kids in them, and so it's hard to make conclusions. I think the feeling is that kids probably do have a bad outcome, but I think this is actually frightening in many ways. So it's this is the information we need to be out there, and so congratulations first on doing this, which is a big undertaking, and you know, and shining the light on this huge issue. which is just getting worse and worse. And I think unless we shine a light on it, then we're not going to get those earlier interventions, and we're not going to make a difference. And people talk about differences in death rates of going from whatever small to something small, but these are kids, and that's a lot of kids dying, and we should be paying attention to that. And so congratulations. It's interesting. I was looking through the paper very closely because I find your work very excellent and really interesting. And when I look at the population that's Nafld compared to the controls or whatever, and you look at things like diabetes, the rate of diabetes is like 20-fold higher, right? And then metabolic comorbidities, I'm not sure what they are, but that's like 27-fold higher. And even at baseline, the cardiovascular issues were like 5-fold higher, whatever. I'm just wondering, hey, these are sick kids. Like these are kids that are really off the normal sort of distribution. I wonder what you think about that. And also, are the kids that are actually dying of NASH or Nafld, are they actually the kids that have these comorbidities at index?
It's a great question. So because the absolute numbers of deaths were relatively small, we looked at each individual death in this population, and they are a sicker population. They very much tended to have type 1 or type 2 diabetes at baseline, which was something, due to the small size of our population, we weren't really able to tease apart the specific impact of type 1 diabetes, which could be quite different on the rates of outcomes in this group. But they did have much higher rates of these metabolic comorbidities, which included obesity, hypertension, or dyslipidemia, and also cardiovascular disease at index at the time of the baseline biopsy. It is quite possible that added some degree of selection bias, which certainly could have influenced our results. Because these kids are sicker, they potentially were more likely to be sort of receiving medical care. They were more involved with the medical system, more likely to get a biopsy. And it made us all wonder what the corresponding rates would look like if we were to take the entire population of kids with a diagnosis of Nafld, not just those who underwent biopsy, who certainly were sicker. And it's difficult because even with the largest study to date, we still had only 718 children and young adults. And so what that really will require is a bigger multi-country effort, I think, to identify kids and young adults to identify a large enough population with.
And of course, we all know as parents that, when we're looking at writing a paper, we go, oh, darn, I wish we had more kids that had liver biopsy. Of course, when then it was your kid, they go, well, I don't know about it. Maybe we'll try some things before a biopsy. And we all know how we are as parents, right? So very, very hard to get, even though I think it would inform care and society at large. When it gets down to the individual person in your office, it's always a little bit challenging. And I don't treat pediatrics at all, so.
Yeah, congratulations. I think this is really a great paper, and the natural history of pediatric fatty liver disease is largely unknown. I mean, before this paper, there was only one paper by my good friend and mentor, Ariel Feldstein, that followed a cohort of only 66 children at the Mayo Clinic. And the average follow-up was about 6.5 years. They followed some kids up to 20 years, and they had actually 2 children that needed liver transplantation. And one of them had a recurrence of NASH after transplant and ended up actually dying, unfortunately. So, I think this is definitely a great contribution. It puts in perspective the real risk of pediatric Nafld. I think we know that pediatric Nafld does not follow the exact same pattern as adult Nafld. There are differences in the histology. They have less hepatocyte ballooning, so the definition of NASH sometimes can be a little bit tricky. We also don't understand the fibrosis progression. I mean, I see kids, especially Latino ethnicity, with stage 3 fibrosis at the age of 15, 16. And then they don't progress to cirrhosis the way you think they will. Some of them do, but maybe there is a more robust fibrolysis mechanism that takes place in younger adults. We really don't understand. But, we've published studies looking at the prevalence of F3 fibrosis in children, and you find these cases. I mean, at least in the, patients referred to large centers, about 10% will have F3 fibrosis. It's definitely not translating into cirrhosis in 5 to 7 years. So there is more to the story. I have a couple of questions for you, though. Number one is, I know the sample size is smaller, but did you have any data on fibrosis? I didn't see much in the paper, and did that affect anything? And then the second question is related to mortality in terms of cancer. I mean, I saw that, the hazard ratio was definitely higher in Nafld, but what cancers do we know? What cancers they died from? Was there a specific one that jumped at you?
Thank you so much. So these are great questions. We were very interested in fibrosis, but unfortunately, when we tried to do direct comparisons, our numbers got very small. We also, anecdotally, we saw that there were a surprising number of kids and young adults who had relatively advanced fibrosis on the biopsies that we were able to, the path that we were able to review from the reports. But we very much are hoping in the future to expand our cohort so that we can look specifically at that question and also look at risk factors for progression and adverse events, because just like you said, it seems as though the natural history is slightly different than what we see in adults. And so it's possible that certain risk factors may have an outsized importance in kids and young adults that we wouldn't necessarily otherwise expect based on what we look for in adult populations with Nafld. So it's something we hope to do in the future, but we weren't able to do meaningful analyses with fibrosis in this particular cohort. Cancer was a sort of a surprising outcome for us, to see those rates was surprising for me. The largest number of cancers among the Nafld patients were liquid malignancies. They were hematologic cancers. But then there also was breast cancer, brain cancer. And again, the absolute numbers were small. And so it's hard to know exactly how much to make of the cancer risk in this population. And I think studies in the future looking at incident cancer would be helpful, because it's hard to know exactly what treatments those kids received, and if perhaps the cancer risk might have been, those cancers might have been diagnosed years ago, decades ago, before treatments have changed and evolved. And so I think a more focused analysis is probably needed, looking at incident cancer in this population.
Is there a chance
Sorry, go ahead.
because they had liquid cancers that was an indication for liver biopsy because of elevated liver enzymes that are already established in a medical center, and then we ended up seeing that increase in the cancer risk? It was striking to me to see the cancer piece at this young age, although you had a very long follow-up. So I mean, some of these individuals obviously will develop cancer, but the rates were very high.
Exactly. And we tried, we tried a few statistical analyses to try and address that question. So we tried to create a lag where we excluded people who had cancer diagnosed within 2 years of the index biopsy to see if that made a difference. And it didn't change our estimates, but you're right that, if there was a concern for cancer or a diagnosis of cancer that somehow had not made its way into the registers, it certainly would have prompted a liver biopsy, and that could have led to the diagnosis of Nafld. Absolutely.
I'm sort of wondering, I mean, in pediatrics, there's, especially when you get kids that fall off the normal distribution, and I know by no stretch of the imagination a pediatrician, but they're often they're tied to syndromic or some genetic issue. I know you did match with siblings and whatever, but of course often they are just one-offs, right? I'm just wondering if because these kids are obviously very deranged metabolically, and that you're picking out. In fact, what you're seeing is the metabolic drivers, just like when you see genetic defects that drive IBD early on or whatever, that this is we're actually seeing a genetic change in a child that is making them have their whole metabolism out of whack, which then drives a more aggressive NASH. And just what do you think of that? And that also, of course, might predispose them to cancer, right?
I think that's a very valid concern that we share too. We, you know, in these administrative data sets, it's always challenging for us to make sure that we are excluding all possible, especially rare diagnoses. Many of them have diagnosis codes and then we can capture them, but some don't. And some may not be adequately recorded. And so there's always the potential for some degree of misclassification. What we tried also to validate the pathology reports in as many of the Nafld patients as we could, often because the indication for biopsy could be edifying, both for the question of the risk of underlying cancer, but also for the risk of an underlying genetic syndrome. And we didn't find, after we did our exclusions, we did find that it seemed as though we were accurately capturing Nafld and NASH, but I think that is also a very important limitation of this study, because we don't have the most granular data from medical records, for example, for these people.
And there's you know, the one thing about the portal inflammation in child Nafld versus adult, it's interesting because I typically review a lot of biopsies with a pathologist and pathologists, and I do see an adult Nafld very commonly, and adult NASH, portal infiltration, lymphocytic infiltration. And so we actually had a single topic conversation meeting here in Canada last February, and Dr. Brunt from St. Louis was on, and I sort of said, you know, this is not in the, you know, we see it all the time. It, you know, no, it's never commented on. It's not part of the scoring system. And she said, I wanted it to be part of the scoring system, and she felt it should have been in the adult because it actually correlates. There's a very nice paper that correlates with more aggressive disease. So I'm just wondering, in the adults that have this lymphocytic portal infiltrate, what we're just seeing in the kids is they're just the adults that have this more aggressive disease. The kids just have it more commonly, and that's why you're seeing it, because they're the ones being biopsied, right, as kids.
That's so interesting.
Yeah, very interesting.
Very
Isn't that cool? It was a very interesting discussion. Yeah. That's online. You can look at. It's a very interesting discussion. She's very. It's always interesting to talk to pathologists who have been around a long time, and just start to get them to talk about what they've seen, right? Because nowadays we're all so busy. I think it's a different type of busyness, and often we don't have the time to go and look at the biopsies. Like a lot of traditional hepatologists who didn't actually have any treatments, but they were very good at, you know, it was all really about diagnosis. It was a little different.
You know, I can comment on this, Mark. We actually published a paper because, as you said, you know, portal inflammation is very important in pediatrics. So instead of the Nafld activity score, we developed one we called the Pediatric Nafld Histologic score, PNHS, and we added 2 points to portal inflammation. So instead of going from 0 to 8 like the NAS, it goes from 0 to 10. So we still had ballooning, portal inflammation, steatosis, but we added 2 points for portal inflammation. We published it in the Journal of Hepatology. It never got any traction, but I think it's very important. The other thing is from the NASH Clinical Research Network, they had a few kids with paired biopsies, so they can follow disease progression in terms of histology. And it seems like around the age of 12, 13, these kids start transitioning into more the adult type on histology. Ballooning starts showing up, and they have more sinusoidal disease now. So I'm not sure that they continue on this trajectory of having very severe disease, or it has to do with a certain pathway, hedgehog, beta-catenin, why it's more localized in the portal area. We don't know, but it's very interesting and very intriguing. And exactly as you said, I mean, we talk about it as if it's a pediatric phenomenon, but it's not. We see it in adult liver biopsies.
I wanted to ask a question. Mark, you used the term metabolic derangement, I think.
Well, they want to change the name to Nafld, right? Which is really, implies that, right?
So in this population, what do you think is the original cause? All of you can comment on what's causing the Nafld in the first place with this young group.
Well, I think that's a very good question, and I think Tracey's paper, because they use the sibling. I mean, you sort of think, oh well, maybe it's just environment, right? And maybe it's what the family's eating. But I think by having the siblings as controls, then I think you're going to do as well as you can do with regards to an environment sort of thing. And so then, is it that maybe they come from a broken environment or whatever. So one child's with this environment and the other child goes with this, or something that influences that, or it's genetic, right? There's something in there. And I expect it probably is, because these kids are developing at an early age, and it's obviously aggressive. They're dying young, right? And so there must be. These are just like, you know, with IL-10 and IBD and all these different things. I think the kids that have these aggressive syndromes, and really I would say it's like a syndrome almost, are going to tell us a lot about what are the genetic drivers and potentially the environment. It might be a kid just likes to drink Coke, right? And the other one doesn't. That just happens to be it, even though they're siblings. And that, you know, and they drink a liter of Coke a day, right? You know, or whatever, 2 liters a day. And so, as we see quite commonly in the clinic, and that's a huge driver now, right?
We maybe they have to get to the point. I don't know, Tracey, if they did that, but did they look at? Was there any kind of survey about to try to correlate some of the cause?
That would be fabulous. We would love that, and would be thrilled to find a cohort where such data were available. But unfortunately, these administrative data sets are based solely on diagnosis codes and recorded diagnoses put in by treating physicians. And so to date, there hasn't been a large prospective analysis of diet and lifestyle and environmental factors in relation to long-term outcomes.
You
three need to get together to do a prospective 10-year study.
Yeah. You know, Michael, there are studies looking at obese mothers with gestational diabetes, and doing MRIs on neonates as young as 1 month of age. And these neonates born to obese mothers have more fat in the liver. We don't know, you know, if they're going to continue to have fatty liver later in life or not, but I think there's an epigenetic factor also. You know, when you're born into that environment in the womb, in a way, it affects your metabolism for years to come. I think also it's not all the exact same disease. So the most aggressive pediatric fatty liver disease you see actually in a group of kids with pan-hypopituitarism. They really have metabolic derangement, but they progress very fast. And, you know, I've seen kids with NASH cirrhosis as early as 14, 15 years of age. So, you know, that's kind of like a subgroup of these patients that have the most aggressive form. Also other, you know, genetic factors, as Mark mentioned, I've seen severe disease in kids with the MZ phenotype for another genetic liver disease we call alpha-1 antitrypsin deficiency. They don't have the disease, they are carriers, but they progress faster. And I've seen a few kids with F3 fibrosis and one child with NASH cirrhosis at the age of 13. She had diabetes, obstructive sleep apnea, hypertension, dyslipidemia, and MZ phenotype. And she had biopsy-proven NASH cirrhosis. So there's more to the story. It's, I mean, I can tell you some scary stuff related to children with aggressive disease, and we've transplanted definitely some young adults for NASH. Tracey, I have a suggestion for you. In the oncology literature, they use a term called AYAs, which is adolescents and young adults, and they go from 15 to 39. And actually, you know, there are many unanswered questions about the natural history in young adults, and you can push it all the way to 39. So maybe that'll be your next paper. Look at this AYA group. You'll have more patients for sure.
It would help with the numbers. Yes, we'd be able to do some more detailed analyses.
Go to 50. 50 is the new 20. I just, you know, I was thinking as we were chatting there that I'm just wondering if there's a relationship between birth order. I mean, if there's an imprint that's epigenetic that's based on weight gain of the mom, often as sequential births, the moms gain more weight. I'm just wondering if there's actually a birth order effect that might be a driver of more aggressive NASH, depending on where you were born in a family. What do you guys think of that?
That's very interesing.
I think
that's a testable question.
That is a testable question. That's why I said. Because I mean, that might answer that question. Because I mean, I bet you there's data on average weight gain between pregnancies, or weight that you accumulate between pregnancies. I'll bet you there is in the obstetrical literature.
I mean, it's really important for us to be able to take something away from all the work that you did in the study, that, you know, things that we can either lead to other studies or things we can learn about screening, or as Naim said, maybe, you know, the weight of the mother before would be one of those indicators for, you know, early assessment, right?
And you know, and to tie into the MZ phenotype, many years ago when I was at NIH, we actually published a paper that actually got a little bit of discussion around, where people on methotrexate seemed to have a more, well, obviously causes fatty liver and fibrosis, right? That had a more accelerated sort of clinical picture if they were an MZ phenotype. So I'm just wondering if that all might come together. That might be something that's probably might be important to look at, actually.
Well, on that note, Mark and Naim and Tracey, thank you very, very much for another incredible paper and discussion. You need to write another one so that we can have another one.
That's right, yeah. In the next 2 months, go for it.
If you can please get on that. I'm sure that we could find other incredibly important topics for people. And so thank you so much again for sharing your insights, and it's going to help a lot of people.
Yeah. Thank you, Mike. And thanks, Tracey. That was really a wonderful paper.
Oh, thank you all so much.
Yeah.